Hello. Thanks for having us today. And I really wanted to talk about a topic that oftentimes is a little bit, I wouldn't say it's controversial, but there's been a lot of differing opinions over the years, and certainly maybe has landed us where we are today. And how can we really optimize the use of therapeutic drug monitoring as we think about precision medicine in treating our patients with inflammatory bowel disease? And I know that many of you are pediatricians and in the pediatric GI space, and you all know too well that we don't have a lot of options, not nearly as many options as we have on the adult side. And so optimization of therapy is so incredibly important for those kids sitting in front of you. I have a few disclosures related to companies that also make some of the drugs that we are doing therapeutic drug monitoring in. So some just learning objectives to walk us through today, and we'll have a Q&A at the end. So if there's any burning questions, I'm also happy to keep it informal. And if there's a question on a particular topic that I'm talking about, I'm happy to answer it real time. We're going to discuss the role of therapeutic drug monitoring in the management of patients with inflammatory bowel disease, something that you're doing every day. Review reactive and proactive drug monitoring strategies. Identify patients at risk for high drug clearance and maybe different strategies that we can use as clinicians in terms of managing those patients and preventing potential loss of response. And then define the differences between different aspects protection, which is often something, at least with our trainees, which can be very confusing, especially if you're interpreting orders from maybe from various different companies outside as to how do those differ in terms of how they're assessing both drug levels as well as anti-drug antibodies. This slide is not new to you. You understand that there's a timeline in which is often delayed in our patients with inflammatory bowel disease in terms of the evaluation and management. Ideal state, we want to understand symptoms early, recognizing them, and provide an accurate diagnosis. But future state, maybe it's that we're identifying patients before they even present or have phenotype of inflammatory bowel disease, those that are at risk for future development. When we do identify patients, we need to risk stratify them. Not all inflammatory bowel disease is created equal, and nor does it have the same prognostication. Although in many children, we know that there is a more significant disease course. When we see patients on the adult side, not everyone will have that progressive disease course that you may see on the pediatric side. And not only do we have to understand what their risk stratification is, but defining their current severity as we go through thinking through early and appropriate treatment. Now, in early and appropriate treatment, maybe this is where proactive drug monitoring and therapeutic drug monitoring can come in so that we can truly optimize that patient. And instead of doing the opposite, which is what many of us have probably been doing for a really long time, which is reacting. That patient in front of you is not having that ultimate treat to target approach. They're not reaching clinical or biochemical remission or even endoscopic remission. And so we're understanding why that might be. And there still may be a role for reactive drug monitoring in some patients. Now, many of you are familiar with this treat to target strategy from the STRIDE 2 guidance, and we do anticipate some STRIDE 3 guidance coming out. What they don't talk about in the treat to target strategy is where do you put in therapeutic drug monitoring. And I'll argue that anywhere there's a star, you can see that there's an opportunity, both early in disease treatment as well as throughout maintenance of treatment, to be able to assess whether or not that patient has appropriate or adequate levels for their particular disease severity and type. And I say there because there's really truly an opportunity to personalize the way that we're treating these patients. Therapeutic drug monitoring is important for treatment optimization because we know, again, that not all IBD is the same. We've seen many patients with Crohn's disease that otherwise on paper can look very similar, but we know that their disease phenotype is very different. We know that disease severity and or extent might predict a potential reduced response. An example would be a patient that's hospitalized with acute severe ulcerative colitis. We know that those patients actually require the highest amount of drug to be able to potentially achieve a level of healing. We've learned lessons from prior immunosuppression therapies, including both non-IBD as well as IBD-related therapies. Many of our therapies have different pharmacokinetics, and they have different pharmacokinetics among different users. Anti-drug antibody formation is variable, not only again amongst patients, but it's also based on the therapy that we choose. And optimized therapy can be associated with higher clinical response, and at least the data is really robust within the anti-TNFs, which we'll talk about, but also the association of lower adverse events, lower risk for disease progression, and reduced need for surgery. So what did we learn previously in terms of other therapies? So we know that it's so incredibly important that in a post-transplant state that we're monitoring tacrolimus. Not only do patients get different drug dosing, but we know that the levels are associated whether or not that patient will lose an organ, and that could have catastrophic outcomes. Vancomycin, patients get different dosing, and we titrate their dosing, and we know the clinical effects and response based on a particular vancomycin level. And then we learned early, one of our first therapies, immunomodulator use. So we knew from both the 6-mercaptopurine and the azathioprine that there was a significant clinical response associated with particular 6-thioguanine levels. So we learned early within the IBD space that dosing and being able to monitor that dose very much had an impact on outcomes. And then introduce infliximab. And many of you have been practicing where infliximab in 1998 was approved for episodic therapy. So it wasn't given as we think about it today. And then in 2002 to 2004, it really is when the ACCENT-1 and other studies really showed improved outcomes and decreased immunogenicity with more scheduled dosing, both during induction and maintenance. We progressed forward in the SONIC trial in 2010, where we found out that actually patients did better when they were on a combination approach. And of course, many of us know that the post hoc analysis really showed that the importance was that of drug levels and less so whether or not that patient was on combination. 2014, we start to see the introduction, so 11 years ago, of proactive drug monitoring, and dose optimization was associated with less discontinuation than standard of care. And I'll show you some of that data as well. And then fast forward in the last 5 years, a lot of this studies that have been done both in the pediatric and adult population using the PANTS consortium found that HLA-DQ-A15 was associated with an increased rate of formation of anti-drug antibodies and associated with worse outcomes. So maybe that help inform us which patients we should have probably never been using episodic infliximab therapy on, 30 years prior. And of course, our understanding of TDM has changed over the years. And we had the 2017 AGA Therapeutic Drug Monitoring Guidelines, and then the update meeting summary coming out of a pretty robust group, really led by Dr. Corey Siegel as senior author here, but the appropriate use of therapeutic drug monitoring. And then more recently in 2021, from the American Journal of Gastroenterology, a comprehensive literature review, and then overall expert consensus that came out because of course, our toolbox is expanding. The opportunity to do therapeutic drug monitoring outside of just anti-TNFs is also expanding. So how do we utilize that in our practice? So what do we know about therapeutic drug monitoring in inflammatory bowel disease? Well, there's definitely well-established data about the role of TDM in anti-TNF therapies, but we know a little bit less about non-anti-TNF therapies. We also know that serum drug concentrations are higher in patients that have lower levels or no inflammation. And then we also know that ongoing inflammation is association with lower drug concentrations. So these associations are important, but that does not necessarily mean causation. So there may be an opportunity where we try to push patients to a drug level that is able to achieve a level of healing for them. So you often hear reactive versus proactive drug monitoring. So reactive drug monitoring is the evaluation of drug concentrations and anti-drug antibodies is a primary non-response or a secondary loss of response to treatment. So the patients that I see today who had overall been doing well, now coming in with increasing symptoms and fecal calprotectin is elevated and they're on infliximab monotherapy. Seems reasonable that I should be able to get a drug level to understand what category that patient fits in terms of my practice. This can be very cost effective, especially as opposed to empirically dose escalating them, knowing that up to 20 to 30% of patients on infliximab monotherapy may form an anti-drug antibody over time, highest in the first year. So certainly if I empirically dose escalate, there's about a third chance that I might be missing an opportunity to find either a more optimal way to manage this patient's disease. Proactive drug monitoring is the regular measurement of drug trough concentrations with and anti-drug antibodies and a dose adaptation to target the appropriate drug concentration, which we'll talk a little bit about what is the appropriate drug concentration and is there a one-size-fits-all approach to that. But this has also been associated with an improved therapeutic outcomes over dose optimization and even with reactive TDM. And I'll show you a meta-analysis that was recently done. But what we do know is that retrospective, prospective, and post hoc analyses have shown higher drug concentrations are associated with improved therapeutic outcomes. So it doesn't mean necessarily just giving patients more drug, but using drug levels and anti-drug antibody measurement to be able to guide that treatment decision. So in this particular study, they looked at whether or not proactive versus reactive led to more discontinuation of therapy. And as expected, if you buy into the proactive drug monitoring, and I know many of you in the pediatric world do it far better than us in the adult world, where when I see a patient transitioning from your clinic, they often have more drug levels than I've seen in our practice. And so you're very much participating in that proactive monitoring approach, especially with TNF therapies. But you can see that patients are significantly more likely to have persistence on infliximab if we're doing proactive drug monitoring, which of course you can extrapolate means that we have opportunities to do dose optimization in a patient that is maybe otherwise well, the sort of the basis of proactive drug monitoring. This is a meta-analysis that looked at 26 studies, including 9 randomized controlled trials that had varying endpoints. But overall, it was a fairly well-done study that was able to see that treatment failure was more common in patients undergoing standard of care than proactive drug monitoring. And there was a trend towards need for hospitalization. There were no changes in outcomes in clinical remission, endoscopic remission, or surgical intervention in this particular meta-analysis. And then when they compared proactive drug monitoring versus reactive drug monitoring, found that treatment failure was more common in reactive drug monitoring and need for hospitalization was more common in reactive drug monitoring. So overall, proactive is better than standard of care, at least based on this meta-analysis. And then proactive is better than reactive, and based on this meta-analysis in terms of achieving some of those really important endpoints and outcomes that we care about in our practice. So how does this look like in practice? And you all should, I'll ensure that I share a PDF of these slides so it's easier for you to view. But secondary loss of response, we've just identified that this patient has disease activity, right? There's lots of patients that come into our clinic that have lots of symptoms. Patient I saw today with lots of diarrhea, has a history of bowel resection, but her fecal calprotectin is normal, her CT enterography is normal, and her colonoscopy is normal, but she does have a stricture. So that's not necessarily a patient that's losing response to medical therapy. That's a patient that has another explanation for their symptoms, stricture plus or minus potential bile acid malabsorption. But in this particular situation, if you did confirm that a patient had activity, we want to make sure that that patient has therapeutic levels of anti-TNF, and I'll go over shortly where those sort of ranges have fallen out over the years, versus a subtherapeutic concentration. So are they at a level of at least 15 to 20 in their anti-TNF? If so, and they've got pretty good disease activity, this is where we would want to change to a different class, or if indicated in the right patient, potentially consider surgery. If they're subtherapeutic, now we need to understand, are they subtherapeutic because they've formed no anti-drug antibodies? This is an opportunity in a reactive sense that we could dose escalate them. Of course, the limiting factor being insurance and somebody paying for it. And then, or do they have anti-drug antibodies? The thing that we often see, and you probably see this in your practice as you get referrals from the community, is that patients and providers, they see an antibody, no matter what the level is, and no matter what the drug level is, and they discontinue the therapy. They see antibody and then they stop therapy. And I think that that's probably one of the biggest things that we hope to change, I think, as a community caring for these IBD patients, is that not all antibodies are created equal. So if the patient has subtherapeutic concentrations and a low level antibody, this is where we have the opportunity to really change what happens moving forward. This is where I would take a patient and I would dose optimize them. I even would probably, especially in a pediatric situation, add an immunomodulator, either in the form of azathioprine, 6-mercaptopurine, or methotrexate, depending male or female, and you guys are all well versed in that. But if the patient had high levels in subtherapeutic concentration, I think I'd have to see what the level is. So the antibody matters less to me. I really want to understand what that level is. Because if they have high level antibodies, but they have a lot of drug around, so maybe they're not where they need to be, we don't always need to switch. We can overcome some of those antibodies with dose escalation, and some of those antibodies may be informing us of a non-neutralized antibody. But this is also an opportunity in the right patient to switch within class. If we felt really strongly that we needed to continue potentially anti-TNF in this particular example, or if we felt like this patient has cycled through a couple anti-TNFs and that this is now their second anti-TNF, we could go to another anti-TNF, or our toolbox is pretty expansive. We probably need to be considered alternative therapies. In addition, maybe I'd be considering an oral therapy, at least in a patient off-label in pediatrics, but in an adult patient, I'd be considering a JAK inhibitor. Proactive monitoring, you can see, looks a little bit different. So this patient is having clinical benefit from infliximab maintenance therapy. We're seeing that they're clinically responding, and we're checking proactively, not reactively, but proactively their levels. We see that the patient may have a super therapeutic concentration. And I want to use that super therapeutic a little bit with quotes, because there's been some studies that show that there's really no increased risk with more exposure to anti-TNF as long as you're getting inflammatory benefit. But some patients don't need to have a level of 15 if they're in complete remission. So maybe these are opportunities after a steroid-free remission of a year, showing deep remission, which we'll talk about, that we could consider de-escalation of treatment. What happens if that patient falls in that really more middle range, that 5 to 15 milligrams? This is where we may continue the same infliximab regimen, especially if that patient is clinically well. And then, of course, if they have undetectable or very low levels of infliximab, we want to take a look at whether or not they have lower or higher levels of anti-drug antibodies. And then this is where we can consider optimization, adding an immune modulator, again, in a patient who otherwise, if you waited for reactive monitoring, you wouldn't have done this, or stopping the infliximab because you recognize that this patient is about to probably clinically relapse because they are clearing out this anti-inflammatory out of their system. So if I haven't convinced you, which I'm sure many of you agree, that therapeutic drug monitoring absolutely adds value for our patient care. Reactive monitoring is certainly more informative than uninformed switching, right? Oh, you've been on medication A for the last year. You're still having clinical symptoms. There is a little bit of inflammation that's present. Let's figure out really where that inflammation is and how severe it is. You're not doing great. Let's just switch you off that medicine. We know that patients respond the best to the first biologic that we give them. So we really should feel pretty confident that patient is a primary non-responder before switching them. Talked about proactive monitoring and how the positive impacts on patient care. There's been association with improved therapeutic outcomes. I would take that for anything that you offer. We know that low drug concentration plus or minus anti-drug antibodies can be associated with treatment failure. So if I have this person in front of me that I could almost predict with a crystal ball is going to fail, well, I want to act on that before they fail. And then proactive monitoring and infliximab can actually potentially give us an opportunity for de-escalation, which many of our patients, maybe less so in the pediatric world, but in the adult world, are very interested in figuring out, how can I be on less, right? They don't want to stay on long-term multiple therapies. And so this is really going to maybe monotherapy as opposed to combination therapy. So there's challenges in implementing TDM. I'm not sitting up here telling you that it's easy. I feel very fortunate that I get to work at a place that I have access to being able to easily order any of the drug levels that I need with the absence of two, but I often wouldn't do them in my practice. But I have the opportunity to order the things that I need, and I have a fast turnaround time. I usually, depending on when I order it, when it's done, can have results in days, maybe at most a week, so that I can help make decisions for that patient. But not everyone has access to that. And so that's why it's important that we discuss, what is available, and also be realistic about what our colleagues in the community might be doing. So how, is there an opportunity in a patient population that we can reliably predict their risk for forming anti-drug antibodies? What are these optimal concentrations I'm talking about? And what is the data to support them? We all know that, sure, I can get a result. You're about to get your infusion. I'm going to draw an infliximab level on you, but I'm not maybe going to get it back, potentially, if I send it out to an outside facility for weeks. How is that really informing me what I'm doing right then and there? We know that there's different assays, and so sometimes it can be a little confusing to interpret those assays. There's also different interpretation of anti-drug antibodies and what that means. I'm going to tell you that the level is more important than the antibody. There's also lack of robust data outside of anti-TNF therapy. And there's limited prospective randomized controlled trials with that specific focus on proactive drug monitoring, but the ones that do exist all suggest that there's benefit. And then really, at the end of the day, we want to be able to personalize this, not to just the patient on drug A, but to that patient and what is their experience and how much drug do they need to achieve healing, because it may be different from Crohn's patient A, B, C, and D. So the truly personalized approach to care. So I'm going to talk through some of these challenges and ways that we can overcome them. So, if you're not aware of the PANS Consortium, which did an excellent study looking at whether or not there were particular genetic factors that were associated with an increased risk for loss of response or anti-drug antibodies. So, this is pretty convincing data to me. Now, when this was first published, several years ago, it wasn't easy for us to be able to A, get the genetic test, and B, get approval for the genetic test. We found that we're able to do this by doing the celiac testing to be able to get this allele so that we can better inform our patients. But I know that if I was about to start on an anti-TNF therapy, I would want to know this information about myself, and I would want to know this information about my child. What is their risk if I start them on monotherapy with an anti-TNF, doing standard of care, not proactive monitoring? Certainly, proactive monitoring can change this. But if I was going to start standard of care infliximab and I had this allele, I have a pretty high chance of forming some level of anti-drug antibody, which may or may not result in my treatment failure. That's something that I would definitely want to know. You can see that those that don't have this carrier state are still at risk because immunogenicity can happen for many reasons, but they're much less at risk than the patients with the allele. And certainly, if I have a patient or if I was the patient, I would want to be on an immunomodulator because I know that that's at least going to offer me some prevention in forming anti-drug antibodies and then subsequently loss of response. In addition, there's opportunities for us to be informed about clearance. So not everyone clears drug the same. This is not a novel idea, right? We know this based on thiopurines that people respond differently to these drugs. They have different enzyme levels that break down these drugs. The same thing is happening with the biologics. This particular study is looking mainly at infliximab. And so what it's showing, and this is infliximab, I'm sorry, and adalimumab. I want to point out that ADA on this slide means adalimumab. There is a confusion because ADA throughout the talk is anti-drug antibody. But if you have higher clearance of infliximab, if you have higher clearance of adalimumab, it's associated with a significant increase for lack of response. So that's something that I would want to know before I'm about to start a therapy that is a very effective therapy to treat disease, but it may be not as effective in me if you're going to use the standard FDA dosing. So this is something that's really important. This is work out of Mount Sinai that was from Dr. Marla Dubinsky and Lizzie Spencer. So this was follow-up to this is, well, if you have HLA status and you have high clearance, what are ways that we can overcome that, right? Like I can't change your HLA status and I can't change how fast you clear drug, but are there things that we can do to be able to? So A, knowing that is really, really important, but proactive precision guided dosing in those patients that are at risk for loss of response can be overcome. So if we're proactive about our monitoring and we're proactive about our drug optimization, these patients that are at the highest risk for lack of response or loss of response over time, we may be actually able to overcome that. So what are these optimal dosing concentrations? And this is a lot of the work that's been published from Dr. Chaffetz, who is out of Boston. And he's really kind of been the person that's talked a lot about proactive drug monitoring. A colleague of mine, Dr. Vaughn, really had a great, perspective. Instead of asking what the target concentration is, if we're really truly thinking about predictive and precision medicine, will this particular patient's inflammation regress when I do dose escalation? So if a patient has a level of 15 on infliximab and they don't have penetrating complications in their maintenance phase, it's probably less likely that I'm going to get any more bang for my buck by getting more infliximab. This would be a patient I need to consider as a primary non-responder. So these really kind of go through, I broke this down based on weeks. So when you can check levels. So if you were being super proactive in induction phase monitoring, typically I do my levels at week 6, and I'll show you on the next slide about what the dosing is shown about week 6. But sometimes you can get them as early as week 2 to be able to see early overall drug level escalation in the blood. Looking at maintenance and right before first maintenance dose, and then overall in a stable maintenance. And we know based on several studies that fistula-related healing need higher drug levels. And so I often aim for a higher level closer to 18 to 20. I outlined them for both adalimumab. We know a little bit less about certolizumab and golimumab in terms of really truly feeling confident that we understand what the really right or more targeted things are. If patients are partial responders and they don't have anti-drug antibody and their levels aren't through the roof, I'm going to dose escalate these particular patients. And I'm using this type of monitoring to help me do that. And then you can see with ustekinumab, vedolizumab, and risankizumab, and I put these over here because those are the non-anti-TNF therapies there. These are based on the AGA consensus from 2021. And certainly looking through the literature, there's not been much change in terms of understanding overall target levels for these particular drugs. So pediatric dosing, this is a study that you're probably aware of that was published about 10 years ago, only in about 112 children, but for a pediatric study, that's actually quite good. You can see that in patients that are in the pediatric population for Crohn's disease started on standard FDA label approved dosing, that few of them reach that target. They really are having a hard time reaching enough drug level. We know that our pediatric patients, are more likely to have lower albumin levels, which is the left right here, and B, need dosing requirements. And this study really helps show this. And this is a great study that we often use when we have patients who need higher drug levels, especially if they're under the age of 18, really showing that literally the majority of them to be able to achieve a specific target level require higher doses. I mean, 10 milligrams per kilogram every 6 weeks is significantly greater than the FDA dosing. Another pediatric and adult IBD, standard infliximab dosing is insufficient in many. So you can see here where you're seeing overall durability. So obviously if people are non-adherent, that's down here, but you're looking at patients that are in standard dosing. You can see that overall the durability is lower as opposed to those patients who are able to achieve higher drug levels. So being able to achieve a higher drug level is able to achieve durability of treatment. So that's now multiple studies are showing this, that drug levels are associated with reduced inflammation and durability of therapy, and a therapy that has risk for loss of response. So looking at these assays, I told you that it can be, challenging to kind of look at these assays. So there's always a potential for competition between the reagent antibody and the circulating antibodies that potentially can affect testing performance. So in the drug assays, and I have a table coming up, there are drug assays that are drug tolerant. That means that the assay can withstand the detection of anti-drug antibodies in the presence of drug concentration. So if your level was 15, it's going to report out that there is potential anti-drug antibodies. There's going to report out at least that the test is potentially positive. Those are most often in the setting of active drug, non-neutralizing antibodies, non-informative. And what we really need is proactive study to show that those patients that have drug levels of 10 with these potential lingering antibodies, which are often transient, so if you repeat it at the next cycle, they may go away, whether or not they lose response over time. And so that is something that we don't necessarily know. Should we be starting those patients with antibodies with high drug level on immunomodulators? Because are they at risk over time to form anti-drug antibodies? Now, on the other hand, there's drug sensitivity assays. So these assays cannot detect anti-drug antibody in the presence of drug concentration. And Mayo Clinic is the only place to offer reflex testing. So you may have thought, what is this reflex testing? So if your drug level is below a threshold, then we will be measuring antibodies to assess whether or not those antibodies are real. This is where we may actually inform you more of neutralizing antibodies. So this is where you'll see that. And I'm going to show you a little bit here. But either way, the lag time between testing and results is often what may be not as informative if the patient is about to take their injection or about to get their infusion. So these are the available assays that we have. And so I put Mayo Clinic Laboratories only because this is what I'm used to using. I used it when I was at the University of Michigan, but I'm also using it now at Mayo Clinic. So we have infliximab, adalimumab, vedolizumab, ustekinumab, and risankizumab antibodies. These are drug tolerant and drug sensitive because we do offer both. And so that's, I think, important to know which one you're ordering. The drug sensitive are obviously where I'm going to give you reflex antibody testing. And then there's drug tolerant, which is where the panel is available. So you're going to get the level and you're also going to be informed about antibodies, which can sometimes be confusing. You can see throughout the rest of them, Prometheus Labs offers lab testing, both the traditional ones you've thought about, Answer, ADA, IFX, ustekinumab, and vedolizumab. They also have some predictor testing, which I'll briefly touch on. And then LabCorp has some, Quest has some. LabCorp is the only one that does certolizumab and golimumab levels, Quest and AURP. These are what you'll see. So this is what's available, at least from Mayo Clinic. So I'm typically ordering reflex because I don't know that I'm convinced that I care about antibodies in the presence of drug. Okay, so reflex antibodies for infliximab, or you can get the panel where you're informed of both. Same thing with adalimumab and vedolizumab. We're only offering panel testing, and my Mayo Clinic team can tell me if I'm wrong for ustekinumab and risankizumab. So what is predictor testing and when am I using it? So I don't get paid as a consultant from Prometheus, but I was a part of some of the studies that ended up getting validation for both infliximab and adalimumab. So what predictor testing is and how I use it in my practice is that patient that's really sick in front of me that like got an infusion 2 weeks ago of infliximab, they had an initial kind of response, but they're prednisone dependent. I don't want to wait 6 weeks for me to figure out why they're failing infliximab, right? I don't want to have to wait to that 8 week mark. What they use is predictive large language models and big models that they've built to be able to tell me if I draw the lab right now, what that predicted trough would be if that patient is on dosing X, Y, or Z, right? So if they're on 10 milligrams per kilogram every 4 weeks, 6 weeks, 8 weeks. And so this is from a real patient that I had recently, normal albumin level, no antibodies, measuring right now at week 2, a level of 16.2. And then it's going to tell me, well, if I had this patient on drug every 4 weeks, this is what the trough would be. But it's going to tell me that if I get to every 8 weeks and my patient with a perianal fistula, they're going to have a trough level of 5. Well, so I should probably just give that dose early. And I probably should escalate that dosing a little bit higher. So it's informing me about their clearance. It's actually telling me what that is. So this is where I'm using that. I'm not using it in every patient, but it is a unique way to be able to test for drug and not have to wait for that next um, uh, uh, infusion. Now, in subcutaneous therapies, when you give them every 1 to 2 weeks, I mean, it's not like we're waiting a long time. But when we're on infusion-based therapies every 8 weeks, it can be challenging. So where are these opportunities to utilize this? Induction reactive TDM. So there's kind of proactive and then there's this reactive. So in the proactive phase, I want to be doing this at week 6. So in my really sick patient, my patient at high risk for drug clearance, my patient with a HLA DQ1 A105 antibody, these particular or allele, these particular patients, I'm doing induction drug monitoring in, and I'm testing this for infliximab before their week 6 dose. And if they're reaching a level of 17, this has been associated with predictive response. But if they're not reaching a level of 17, it's telling me that they got pretty high clearance. And so we know that most patients that we start on infliximab are going to need some level of dose optimization. And of course, there's the opportunity for reactive monitoring, which is if that patient has a partial response, you're checking it at some point with an induction. But I really like the idea of just having it standard at that week 6 mark. We know that this early TDM can improve outcomes. So the PANS consortium, the 3-year follow-up, shows that only a third of patients that are on an anti-TNF are in remission. And the highest loss of response was in the first year. Now, PANS is not looking at what we're doing maybe in practice. It wasn't about dose optimization. It was looking at sort of standard of care. But in those patients that did have potential drug concentrations, we knew that being able to measure that early showed us that early TDM plus or minus combination therapy was associated with better short term, that 1 year, but also 3-year outcomes. But everyone else seems to be falling off if we weren't doing that. What about those patients in deep remission? I just saw a patient, clinically remission, fecal count protected normal, CRP is normal, absolutely no symptoms, has been on drugs stably for the last year. They've been on an anti-TNF. Should I be checking a drug level in that particular patient? So we know that about 15% of patients, even if they're stable, deep remission, achieved healing, can have low drug and detectable anti-drug antibodies. So that is an opportunity to change what happens to that patient. If a patient is in remission and they have low risk for anti-drug antibodies, they're either on combination therapy, they have a history of good levels, there may be lower value here, but I still don't think it's absolutely zero value. It informs you that this patient needs a level of X to be able to achieve this level of healing. Now, if patients are in deep remission on anti-TNF monotherapy, the greatest value is actually potentially understanding whether or not this patient will future lose response. So if you're tracking this over time and you're looking at data, as the level potentially goes down on their drug level and the antibody potentially is going up, especially if you're using a paneled antibody, not a reflex antibody, you might just see like this patient's going to have the opportunity for loss of response. And that's something that could be preventative. The old teaching is once you started a drug, you could never go back to it. We all know that that's no longer true, that there are some patients that we can safely resume on an anti-TNF therapy after they've discontinued it. I put this slide together for you all just so you can see some of the induction or reinduction or re-exposure if patients have been exposed to a drug in the past. We do this quite frequently in our practice because we see a lot of patients that were started on infliximab, taken off of it because it was, quote, not effective, did not have any therapeutic drug monitoring, so it never informed us the why. But they felt like it really was the most helpful of all the therapies now they've been on. That was the best they felt, even if it didn't really completely give them remission. And so in these particular patients, we'll do a reinduction protocol where we're using therapeutic drug monitoring to guide whether or not we can give dose number 2 safely. We know that up to 40% of patients can form an anti-drug antibody after 1 week of re-exposure to drug. So what I've seen happen previously with some of my trainees is they were checking the antibody and the level before we ever re-expose them to the drug again. Again, that cross-reactivity potentially with autoantibodies, you may pick up people that form an anti-drug antibody and they've never been re-exposed or never been exposed. I actually formed an anti-drug antibody to infliximab low level when I was accidentally tested. Somebody put in the wrong order and I've never been exposed to infliximab. So that being said, testing before you re-expose somebody to the drug is actually not helpful. So testing 1 week after, if you can, if you have availability like we do here to be able to get that drug level back quickly. If not, then you can do that second reinduction protocol that's right here, which is you test 2 weeks and you give dose number 2 at week 4 instead of week 2. But here's where you could use therapeutic drug monitoring and re-exposure to biologic therapies. And then de-escalation. Our patients start a drug. They're already asking day 1, when can I stop it, right? They want to know when they can come off of this awful therapy that we're putting them on. That's their words, not mine. But oftentimes in patients, when they really do reach that deep remission, we can employ a de-escalation strategy, and we have to use therapeutic drug monitoring to guide us in that strategy. So STORY trial was a trial that looked at patients who are on infliximab combination therapy, and they either stopped their immunomodulator or they stopped their infliximab. And those with an overall low level of infliximab prior to going into the de-escalation phase were the ones that were the most likely to do well because they didn't really have a lot of drug around in the first place. So it wasn't probably really helping as much as they think. So how do you do this in practice? And you can see the STAR and then also in the repeat, therapeutic drug monitoring is ingrained in a de-escalation strategy. This is a TNF example. So we're going to get a TNF level. If they have high levels, it may be working more than we think it is. So maybe we want to stop the immunomodulator if they're on combo. Maybe they're on 4-week dosing. Maybe we want to take them to 6 weeks. Maybe we want to decrease the dose overall. If they're on 10 mg per kg every 4 weeks, maybe we go to 7.5 mg per kg. But everything requires us to repeat TDM to assess whether or not that patient is able to maintain level and forms an anti-drug antibody. Same thing, if you've got patients with an quote adequate level of TNF, maybe you want to decrease their immunomodulator or stop their immunomodulator. But every time you're going to be reassessing their drug level as well as overall what their disease activity is doing. And then when else would you use therapeutic drug monitoring? How about if you have a concern for treatment side effects? The patient swears they get this infusion, they feel terrible after they get the infusion. Well, we know that anti-drug antibodies have been associated with clinical adverse events in biologic therapy, lupus-like reaction. We know that antibodies are associated with drug clearance. So if you don't know what their level is and you don't know what their antibodies are and they have a level of 0 and now they're relapsing in front of you, we do know that this is where proactive drug monitoring can be helpful. But certainly if they're telling you, I think, I'm having worsening disease, that reactive part. You can see low levels of anti-drug antibodies in both acute and delayed infusion reactions. So there's information that we can gain there. And then we know that anti-drug antibodies are associated with a higher rate of discontinuation. I've sort of told you that story throughout. So this is where we would want to be using therapeutic drug monitoring to assess for side effects related to therapy. And then this is where I'll go back to understanding anti-drug antibodies. So what's really important is to understand the drug level. And so rarely do I see patients with an absolute drug level of 0 and super high antibodies. What I more likely see is that they have low drug and they may have some low grade, maybe forming some high grade antibodies. Doesn't always mean that they're 100% neutralizing, but this is a table to kind of think about that patient when you get that drug level back. If you're not using reflex testing and you're using panel testing to understand, okay, well, here's my drug level. This is the patient, this is their disease activity in front of me, and these are the anti-drug antibodies. What sort of box does this particular patient fit into? And then how does that inform me in terms of how I'm taking care of that particular patient? But what we do know is that anybody who forms an anti-drug antibody to one biologic has a high level of immunogenicity and clearance, and so they're more likely to form it to a second. The 2021 consensus that was by Dr. Chaffetz and colleagues really looked at kind of when do we do reactive TDM? So They're recommending, based on the consensus, all biologics with a confirmed primary non-response or secondary loss of response. While anti-drug antibodies to vedolizumab and to ustekinumab and to now risankizumab that we can check here at Mayo Clinic are very low when you compare them to anti-TNFs. They're not zero. So they're on the order of anywhere from 1 to 5%, depending on the biologic I listed. So there may be a patient that falls into that rare category. If drug concentrations are at least 10 to 15, or we're saying TDM should happen, and then in infliximab patients or adalimumab patients, get a level of 10 to 15 before you really feel comfortable calling that patient a primary non-responder to anti-TNF therapy. And then reactive TDM, we know, is more cost-effective than empiric anti-TNF therapy optimization. So if you're using TNF in your practice, you should be using TDM of some sort in your practice to help guide that patient, whether it's reactive or proactive. From a proactive standpoint, much of the data around proactive monitoring is TNF based. So going out there and getting a vedolizumab level proactively doesn't really have a lot of data to support it. A little bit expensive for the patient, so it may not be the best choice right now. We may learn more in the coming years as we're using more and more of the therapy. But when should you be doing this, and who should you be doing it in? So for who in my practice is those with severe inflammation, those are at high risk for complications, and those that are higher drug level clearance. So that's usually, there's an algorithm based on CRP and albumin that can help you predict drug clearance. When am I using it? After induction and at least once during maintenance. Reactive therapeutic drug monitoring. If I've done reactive monitoring, now I can inform what I'm going to do next. Then I can do next steps and do more proactive moving forward. When I'm considering combination therapy in a patient, so maybe I can use an anti-TNF optimized monotherapy using proactive monitoring in a patient that is HLA DQ negative, as opposed to convincing the patient to go on 2 drugs. And then after you've achieved that deep steroid-free remission, when you're considering de-escalation of therapy, either dosing or discontinuing your combination therapy approach with an immune modulator. Still, again, outside of anti-TNFs, more data is needed to support proactive monitoring for other biologic classes. And what does the future look like? You know, we sort of talked about what current state is and what's available to us. Well, it'd be the combination of using pharmacogenomics, understanding what that person's risk factors are for developing anti-drug antibodies or having a lower likelihood of response and or complications that have been linked to the HLA allele. Then using pharmacokinetic modeling and dashboards, albumin, C-reactive protein, whether that patient has had anti-drug antibodies in the past, some of the drug concentrations if we're using proactive monitoring, using clinical disease activity indices, and then understanding more of that about that patient. So it's not just patient A, but we actually really know more information. Using therapeutic drug monitoring assays in a future state, wouldn't it be great to get that point of care testing? I get that point of care intestinal ultrasound in my practice. I'd love to be able to do point of care testing so that it can inform me what I'm doing right now, not what I'm doing in a couple weeks. And then, of course, being able to do more remote monitoring to be able to assess these patients so that we don't wait for them to come into the hospital, to the emergency room, call into the clinic, or wait for that next visit because they knew it was coming up in the next couple months, but that we're able to predictively and reliably understand which of those patients are going to get sick. Once we get there, I really truly think that we've married, the proactive precision medicine and how we use therapeutic drug monitoring in our practice. So in summary, this is all of the things that I've talked about. Where can we use it in our practice? If you're using it for some of these places, maybe there's opportunity to consider it in other spots. Maybe it's opportunity to consider it more. It's certainly reactive or proactive, which camp you want to fall in. I do both. It's preferred over empiric escalation or even empiric de-escalation of therapy. And it has been because many people say, well, who's paying for this? This is expensive. I've found that most insurances, at least in the state of Florida, are covering therapeutic drug monitoring. And when they haven't, we've been able to convince them that they need to read the guidelines. And it's been shown to be cost effective, and it's associated with improved clinical outcomes and drug durability, right? We want our patients to stay on a drug, and if it's working for them, we want them to keep staying on it. And so we want to ensure that they have that durability. So thank you for your time. Hopefully if many of you are doing this, but if you learned one new thing today, I feel like that's a win.